This is probably the single biggest thing that pisses me off about hearing aid manufacturers. Hey guys, welcome back to the DrCliffAuD vlog. This is vlog number 161, and today I want to talk to you guys about my single biggest pet peeve about hearing aid manufacturers. But before I do me a huge favor, click the like button, it really helps out the channel, and make sure that you hit the subscribe button with notification bell so you get a notification every single time I publish a new video. With that being said, it's greatly appreciated. Now, I want to go back in time here a little bit because I need to provide you guys with a little bit more context about this pet peeve of mine. So when I was literally my first day of grad school back in 2012, keep in mind I did not have a communication disorders undergraduate degree. I came out of an exercise science program, so all of the lingo and terminology that exists inside of the world of audiology, I did not possess on my first day of grad school. Now, to be quite honest with you, I never even asked my fellow classmates who did have communication disorder degrees coming into the audiology program. I didn't ask them if this terminology made sense to them, but I remember very distinctly on the very first day of Clinic 101 with our clinical preceptors teaching this, the term first fit was used. And I remember being like, I have no idea what that actually means. What do you mean by first fit? You mean the first time that you fit a patient with hearing aids? Like what does that ultimately mean? Well, as it turns out, what first fit actually means is that when you take a hearing test and you enter the results of the audiogram into the computer software for the hearing aid manufacturer that you're going to be programming their hearing aids, it creates amplification settings for those hearing aids inside of a patient's ear. So let's say that you have a high frequency sloping hearing loss, you enter those thresholds into the software, the computer algorithm in there is like, okay, well if you have, 50 decibels of hearing loss at 3,000 hertz, 60 decibels of hearing loss at 4,000 hertz, so on and so forth. It's going to do a calculation of how much amplification they believe you need in those frequency ranges, and then when you put those hearing aids in your ears, that's the amount of amplification that you're going to get. And so seems to make a lot of sense, right? Like you have online hearing aid companies taking that exact same approach. So they're basically doing a first fit of the programming of your prescription hearing aids, and then what they're hoping is that that gets you really close to what you need to have in order to hear really well with those hearing aids. But as I progressed through graduate school, I started to realize that that's just an educated guess about what someone might need. The problem is that these prescriptions for hearing loss, the validated prescriptions, are based off of different ear canal sizes and shapes and then taking the average of those. So when you don't actually go in and you verify that you're programming a hearing aid the right way for your unique ear canal size and shape, then the chances of the first fit programming being accurate is very, very low. In fact, there's a different goal that hearing aid manufacturers have when it comes to their first fit programming versus what we would use when we're doing verification of programming to a validated prescriptive target like NAL-NL2, which is the National Acoustics Laboratory Nonlinear version 2 prescription. And yes, they are coming out with a version 3 prescription, hopefully in 2025 or 2026. Nevertheless, I don't want to get too far off base here. So this whole first fit concept is one that a lot of hearing aid manufacturers will really latch onto when they come out with a new hearing aid. So anytime I don't want to say anytime, but a lot of the time when a hearing aid manufacturer comes out with a new hearing aid, when they pitch it to providers, not when they pitch it to consumers. In fact, they don't do a whole lot of pitching to consumers because you're really not their customer. The person with the hearing loss is not their customer. The person who's their customer is the hearing care professional who fits and dispenses their hearing aids. So that's why you can't just call Phonak, you can't call Unitron, you can't call Signia, you can't call Widex and actually get hearing aids from them. They will not sell them directly to you. You have to purchase those hearing aids through essentially a vendor like an audiologist in an audiology clinic, or through a big box store, or online through a vendor online. There's a variety of places you can get these hearing aids, but these manufacturers, they're not selling the hearing aids directly to you, the person with hearing loss. They're selling it to the providers who are deciding if that hearing aid is the right hearing aid for you, okay? And so when they pitch it to us, they often say, okay, like we totally redid our first fit algorithm. Now our first fit algorithms are so good that you don't even really need to verify with real ear measurement if those hearing aids are meeting someone's prescription, because they're always like super, super close, and people love them. And when they get fit with these hearing aids on first fit and they go away for a week and come back for a follow-up, people are like, no, 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 don't touch my programming because it's perfect. And I'm just like, that is total bullshit, okay? We have a ton of research inside of this profession of audiology that shows, that proves that programming someone's hearing aids to their first fit is almost always worse than programming to their prescription and verifying it with real ear measurement. Now, when I say almost, what I mean is that sometimes people are like, oh, I don't like the way that this sounds. But you know the crazy thing? If you give them time, what actually happens is those verified prescription settings that you get from real ear measurement always result in a better hearing outcome. Okay, now sometimes you have to tweak above and below in certain frequencies and make little tweaks and alterations. I totally get that. But once they adapt to the sound of those hearing aids, they always get better speech intelligibility and they have normalized loudness. That is not the case when you do first fit programming. So, why do so many hearing care professionals still do this first fit programming? Well, I'm going to share a quick little kind of segued story with you guys here. So I had a provider who came in and worked with me in the clinic. Fantastic provider on pretty much every level, except for one. And that was, initially anyway, the programming. And here's the issue that happened. So this individual did not start off, working with me. This individual had worked at a different place, had gone through different clinical rotations, and this person had picked up from a preceptor. So a preceptor is someone who's basically teaching you, when you go to that clinical rotation, teaching you everything that they know and trying to educate you along the way. Like I do, I'm a preceptor. I teach students who come and rotate through my clinic so I can teach them how to be an audiologist. So this individual had been going to a clinical rotation and their preceptor was like, okay, now you should never amplify hearing aids above 4,000 hertz. Now, even if you go in and you verify the prescription, never hit the amplification targets above 4,000 hertz because nobody likes high frequency amplification above 4,000 hertz. They'll basically say, this sounds tinny, this sounds harsh, I do not like the way that this sounds, things are whatever, right? So just don't do it. And so what happened is that when we brought this individual into the clinic and we started having them fit patients with hearing aids, there was a lot of like fitting sequences, and we do a 6-week fitting sequence, and we don't really expect people to be coming back a bunch after their 6-week fitting sequence and following our traditional spaced out appointments over the course of the first year for their follow-ups. But this individual was having numerous patients coming in consistently, and we were trying to figure out why. So I did a bunch of chart audits, meaning I went in through all of the programming and the notes and all of that, so to see if I could figure out why are these patients not performing like we would expect them to perform if we followed comprehensive best practices and verified the amplification levels to their prescriptive targets. Like, this is not making sense. And what I started finding is that a lot of the programming basically had these, like, you'd see the amplification going up and then you'd see it drop off the edge of a cliff, no pun intended, at 4,000 hertz. And I'm like, why are we not hitting the prescriptive targets after 4,000 hertz? So I asked this provider, and they were like, well, I was told that if you hit amplification targets or you give amplification beyond 4,000 hertz, it just sounds like garbage, and to the patient. And I was like, well, who the heck told you that? Like, that makes absolutely no sense. Now, yes, sometimes individuals who've had a high frequency hearing loss for a long time, you can't give them all of the high frequency back at one time. You've kind of got to give them like a gradual buildup of high frequency. But like, this thing that you heard from this other person is not actually accurate. But that's the thing about audiologists, is that we rely on the education of other audiologists to help us become better audiologists ourselves. And so after I kind of explained the concept of like, listen, the research is smarter than us, okay? Like, I might feel like the first fit is better, but at the end of the day, programming a hearing aid to a validated prescriptive target is almost always going to give you a substantially better result than doing a first fit or doing some kind of quirky trick that you were taught from another audiologist. What we as audiologists should be doing for the younger audiologists coming up, like happened to me when I was a young audiologist coming up, is to trust the research. Like if there's research showing you that your performance outcomes are substantially better by doing this thing, then do this thing. I'm not going to go and tell someone to do something completely quirky because I'm in a rush to program someone's hearing aids and I don't have time to counsel them on the importance of high frequency amplification. But I guess the point being here, because this is really not a rant on other audiologists and preceptors giving bad advice to younger audiologists, my point here is this. Most hearing aid manufacturers, when they release a new hearing aid, they say our first fit acceptance is substantially better. And if you're not an audiologist who is aware that first fit, even if it is perfect for a person, it is never perfect for everybody. And the purpose of it is to increase first fit acceptance, to get someone to be like, oh, these hearing aids sound really natural. They sound good. They sound comfortable. But they do not do the one thing that is our job to maximize, and that is speech intelligibility. If you had to pick one thing that's the most important thing for an audiologist, in most cases, that would be to maximize speech intelligibility. That is what people are coming to see us for. Now, there are some circumstances where the most important thing to someone is tinnitus relief. There are certain circumstances where the most important thing is music appreciation. There are certain circumstances where the most important thing is being able to stream phone calls so they can hear their significant others or family members or whoever, right? There are always these, onesies and twosies that come in that their main goal is not maximum speech intelligibility with auditory comfort. But you know what? The vast majority of people, that is actually what they're looking for, whether it's in quiet or whether it's in background noise. And every single time that a hearing aid manufacturer tells either a veteran audiologist or a newbie audiologist that first fit on their new hearing aid is so good that you don't need to verify it, they are full of shit. Okay? And this is where I start to really get on my soapbox, and I had an experience today where I was being briefed on a new hearing aid that is coming out, it's not even out yet, and the audiologist, a doctor of audiology who was telling me about this particular hearing aid was telling me that first fit is so good that you fit patients with it, and they're like, this is perfect, don't make a single change to it. And then when they come back for their first follow-up, they're like, nope, everything's perfect. I don't want you to change a thing. And I'm like, you're so full of crap. And it just bothers the hell out of me. And I literally had to call this person out right in the middle of the call, and I'm like, do you even know who you're talking to? And I understand that makes me sound super arrogant, but here's the thing. At this point, if you're an audiologist and you don't know where I stand between first fit and verified fit, then I don't know where the heck you've been, okay? Don't come to me and say that you're basically going and telling all of your reps to tell all of these audiologists and hearing instrument specialists that your devices on first fit are so good you don't need to verify. And that is why there are so many people who struggle with their freaking hearing aids, and it pisses me off, okay? You guys can see I'm getting a little fired up now. Now, I don't hold a grudge on this person. Like, I get their job is to get audiologists and hearing instrument specialists to want to be like, I want to sell these devices. But you know what? You should be leveraging the benefits of the devices. You should not be leveraging it just makes it easy on you. Now you don't even have to verify. You can save 10 minutes here, save 10 minutes there. And you know what? They're all going to love it. So don't even worry about it. I'm like, that's the biggest load of freaking crap I have ever heard. And to hear another audiologist who is responsible for conveying this information to trainers and other audiologists themselves, it blows my mind that that type of crap is still happening. So, moral of the story here is this. Hearing aid manufacturers are going to continue to do what is in their best interest when it comes to trying to get other hearing care professionals and clinic owners and providers to dispense their products to you guys. It is your responsibility as an individual with hearing loss to demand that your hearing care professional follow comprehensive best practices, and one of those best practices is real ear measurement, real ear verification to a validated prescriptive target. And if you do not do that, what is going to happen is that you're going to get fit with these hearing aids. You're going to be like, these sound pretty good. And then you go home and you're like, these are really comfortable and they sound natural. And then you go somewhere and you're like, I still can't understand what the hell you're telling me, because you do not have them optimized for speech intelligibility like you should. That is what I wanted to get off of my chest today. Hopefully this has helped you guys out. Clearly this has really, really frustrated me, and it will continue to frustrate me because this is going to continue to happen. Despite that little blow up I had during the meeting today, I'm sure that they're going to still tell everybody that they try to pitch this new hearing aid to that first fit is so good you don't need to verify, and if you do verify it, don't be shocked when it's dead on prescription, and it never is. And if you want proof of it, just go to HearAdvisor.com and you can look at the initial fits and you can look at the tuned fits. And the initial fits never hit prescriptive targets exactly, and the tuned fits do a substantially better job of doing so, depending on the hearing aid, because some hearing aids just suck.